Cardiovascular disease is a major cause of morbidity and mortality globally. Medicines such as statins, renin-angiotensin system inhibitors, and beta blockers are evidence-based pharmacotherapies for preventing recurrent myocardial infarction and unstable angina, collectively known as acute coronary syndrome. However, their use in older people depend on many factors, such as comorbidity and frailty. The recent development of the hospital frailty risk score allows us to ascertain frailty using linked hospital data. The hospital frailty risk score was developed in 2018 by Gilbert and was published in the Lancet. They developed this score in a cohort of patients aged 75 years and over using the UK hospital episode statistics in patient data collection. They perform a cluster analysis of ICD-10 codes and hospital resource utilization amongst patients identified as frail. They identified 109 ICD-10 codes and assigned weights to each code based on the prevalence in frail versus non-frail patient groups. The final calculated score was classified as low if it was less than 5 points, intermediate if it was 5 to 15 points, and as high risk of frailty if it was more than 15 points. So the aim of our study was to determine the ability of the hospital frailty risk score to discriminate between groups of older patients initiated on statins, RESI, and beta blockers within a year following the hospitalization for an incident of first ever ACS. For this study, we used a Western Australian inpatient hospital data linked to National Pharmaceutical Benefit Scheme data from 2002 to 2011. We used a fixed 15-year look back to identify incident ACS cases from 2005 to 2008. We limited the study to patients aged 65 years and over and discharged alive from their incident ACS. We limited the study to patients naive to these medicines using a fixed 2-year look back in the PBS data. We used a 2-year look back to calculate frailty risk score from the hospital data collection. We performed separate multivariable Cox and competing risk regressions for each medicine to assess their association between frailty and initiation of each medicine within a year of the incident ACS. The models were adjusted for age, sex, residential location, type of ACS, and the Charlson score. We also assessed the goodness of fit using a C statistic with and without the HFRS, without the hospital frailty score. Our cohort consisted of 6,916 patients. 79% were aged 65 to 84 years. 54% were male. 20% had ST elevation myocardial infarction, which is the most severe form of ACS. 70% were classified as low frailty risk, and 9% as having a high frailty risk. 53% were naive to statins, 68% to RESI, and 41% to beta blockers. We use a multivariable Cox regression to assess the association between frailty and initiation of these medicines within 1 year of their ACS. Patients in the intermediate and high frailty risk groups were less likely to receive all 3 of these medicines compared to those in the low frailty risk group. As there may be a competing risk between receiving these medicines and death, we also perform a multivariable competing risk regression. The results we found with this competing risk regression for all three medicines was similar to the results of the Cox regression, which I showed in the previous slide. We were also interested to determine if addition of the frailty risk score to the model improved the model fit. Here we have model 1, which included age, sex, residential location, type of ACS, and a Charlson score. And model 2 has is basically model 1 with the frailty score added. As you can see, when we added the frailty risk score, the fit of the model improved as evident from a high C statistic. And this was for all three medicine groups, statins, resi, and beta blockers. So to summarize, increasing frailty is inversely associated with the initiation of these cardioprotective medicines in older patients with ACS. This may reflect the adage, first do no harm, as the evidence for these medicines is weak in older people. Doctors may be reluctant to prescribe this medicine given the weak evidence for them. It may also indicate suboptimal treatment and care of these patients. If this is so, we need to develop more effective mechanisms for knowledge translation to improve clinical practice. So the strength of the study is the use of routinely collected whole population administrative data to identify and to determine outcomes of these older patients admitted for ACS. This will reduce issues such as selection bias, as well as reporting or recall bias in terms of the medicines dispensed to them. There are several limitations to this study. As with any observational study, there is a possibility of residual confounding, confounding by disease severity, and other unmeasurable factors that cannot be excluded from having an impact on the findings. We are also uncertain if patients dispense these medicines actually consume them. So to conclude, the hospital frailty risk score can be applied to link administrative hospital data to discriminate between groups of older people who receive these cardioprotective medicines following an incident ACS. There is potential for this frailty risk score to be used in other disease conditions. Before I conclude this presentation, I would like to acknowledge the following. Thank you.